I see you walking out. This is the best bit. Thank you, Barry and Derek, for that last talk. Congratulations, everyone, for making it towards the end of the day as well, because it has been a very full-on day. It's been very rich in content, and hopefully you've had a chance to learn a whole great deal, and also ask some questions, and there's some people to follow up with as well, which is fantastic. And I can't even say we're saving the best till last, because everything's been fantastic, but this is pretty good, what we've got coming up here right now. We are going to be talking about education and training with AI. And it's something that means a great deal to me, because I went to medical school back in 1990, and the internet was just about kicking around just there, and I kind of went along hoping to learn about technology and healthcare at the same time, and as you can imagine, there was none of that at all. And even when the internet came along, everyone thought it wasn't going to be anything, and then it was something, and then people said the same thing about VR, and it was and wasn't, and was and wasn't, and was and wasn't, and came back, but there was no training. Along the way, technology has come in, and clinicians and healthcare workers have started using it, but there remains to be no training at medical school. Now, it has changed slightly, but it remains optional training, and I think even medical students going into medical school now don't have any formal training as part of the core curriculum that I'm aware of. These are doctors in 5 years' time, maybe, with nothing set in stone about their training, about the use of digital health technologies or artificial intelligence. And that's just crazy. That's crazy. And that's just one group of healthcare workers as well, because we've got all these technologies in place coming in now. You've heard about them today, and you may be excited about putting them out there. But we have to be competent users of these tools. I talked about this at lunchtime as well. So how do we do this? It can't be an optional thing, really. And in fact, the EU AI Act, I don't know if you knew this, but we're not under the restrictions of that just now, but in the EU, in February 2025, there'll be a responsibility for every employer who has an employee using a high-risk AI product or tool to make sure that their staff are competent in the use of AI, with a maximal fine of 35 million euros if you're not in the EU from February. Right? Now, that's not applying here right now, but I think that's the right level of attention if we want to start using these tools. You know, these are powerful tools that have a powerful outcome as well. So we're going to have to try and address this ourselves in some way, and that's what this panel is all about. It's like, how do we make sure that we understand what AI is, how to use it, how not to use it, how to make sure it's safe, and how we do this for our future workforce, current workforce, and the patients and public that we serve as well. And to that end, I am absolutely delighted to have two great panelists here today with a brief introduction, but they're going to talk about themselves a little bit more. We've got Professor Nick Fuggle over in the background, Nicholas Fuggle from Southampton. You're a rheumatologist there, works with the Alan Turing Institute, so he'll tell you some more about that. And then we also have Dr. Alex Aubrey here, who's made it across from Wales. And he is going to tell us about how Wales is addressing this issue, or hoping to address this issue in a particularly creative way, I think, and we'll be able to show you a video of that too. But yeah, for now, I'm just going to join them. Maybe I'll sit at the far end, actually. Oh, no, I'll sit here. I'll sit here. And we will get started. And the same as the panels earlier on, we're going to save some time towards the end so you can ask some questions too. So as you go along, if you suddenly think, oh, I've got to ask a question, hold on to it. You'll have a chance at the end. But to that, I am going to hand straight over first to Alex. Do you just want to introduce yourself a little bit further and say a bit about what you're doing, and then we'll go on to Nicholas.
Thanks, Keith. Thank you very much for inviting me to talk. It's a privilege to be here, and I've enjoyed the talk so far. So my name's Alex Aubrey. I'm a GP by background, but also the clinical lead for AI at Health Education and Improvement Wales, which is our kind of statutory body to try and help with educating the workforce for health and social care. So my role really is comprised initially kind of mapping the ecosystem and doing a landscape review of where we are in Wales in terms of AI literacy for the healthcare and social care workforce. And we've just submitted that, and the next step is going to be trying to create and implement some educational resources, because as you said, there's a massive gap there, unfortunately. And I think that needs addressing pretty much quick step, given that we are now using a lot of AI models and solutions without potentially having the adequate training and educational frameworks in place to ensure we're using it safely, responsibly, and ethically. So hopefully a very useful role, and yeah, really excited to talk to you about what we're doing.
Fantastic, that's great. And so Nicholas, introduce yourself and then we'll maybe tell me about what's happening at the Turing.
Brilliant, thank you so much. Yes, so hello everyone, my name is Nick Fuggle. I'm an associate prof down at the University of Southampton, where my research centres around using computer vision to try and predict future musculoskeletal outcomes. But the hat that I've got on sitting here really is as one of the co-organisers of the Clinical Artificial Intelligence Interest Group at the Alan Turing Institute. So the Turing has a number of different interest groups in various different areas: climate, fintech, health equity, but this one is centred around the clinical deployment of artificial intelligence. And as a quick plug, there are kind of three main aims. The first is to share. So we have monthly webinars around various different subjects in the area, all of which are available online via Zoom, but also are posted on YouTube. Second is pooling, to be a pool of resources that can feed into other activities within the Turing. And in order to do that, we have what we call supra interest groups. Supra interest rather than sub, meaning above interest rather than less interest. And these are in various different areas, including intensive care and anaesthetics, pathology. We're just about to launch one in musculoskeletal. And they can feed into various different projects, including some of the aspects of the Turing-Roche partnership, which is one of the big strategic industrial partnerships at the Turing. And the third is really around what we're talking about here, is around education. So we have run a clinical AI summer school for AI-naive clinicians, and we're starting to do some work around scoping for a clinical AI curriculum, but also wider than that, a healthcare AI curriculum for potentially everyone working in the NHS. So that's a bit of a brief background.
Well, that's great. So it's a great resource. I had an opportunity to come and speak earlier on. Was it this year? It felt like a very full year.
Brilliant. Yes, January.
Yeah, and so that's where I met Nicholas, and then another event too. And so let's maybe stay with the work that you're doing there first of all. And you're talking about a national curriculum, and then going broadly from clinical to healthcare. So maybe can you just say a little bit about what you're doing about the clinical curriculum first, and then how the broader curriculum might be different? Let me know a bit more about what you're doing there.
So yes, absolutely. So to start with, there is a major disclaimer, which is that this work is even larger than we thought it was going to be, and even more complicated. We had a brilliant scoping workshop in the middle of October with various different stakeholders from the NHS, representation from royal colleges, regulatory, ethicists, and came together and started to scope what might potentially go into a curriculum. But I guess that there are three main areas to the curriculum. The first is the who. So who is the curriculum going to be directed at? Is this going to be for medical students? Is it going to be for postgraduate medics? Is it going to be for continuing medical education? Is it going to be for everyone working in healthcare? Is it going to be for everyone working in the NHS? So these different levels. So that's the who. The second is the what. So what is going to be the content that goes within it? And we can discuss that more in a moment, but of course that is dependent on what the who is. And finally is the how. So how do you then share that information or share that curriculum, and how is that curriculum going to be addressed and educate the group that you're targeting?
Yeah. So there's a really sensible approach to identifying this. What is the problem? And then you move on from that. When it comes to HEIW and what's happening in Wales, are there similarities in how you're approaching this just now?
Yeah, absolutely. And I was lucky enough to go to the Turing for one of the workshops with respect to the curriculum earlier on in the year. And I think it's what we found in our work, and it was echoed there, is that it's very difficult to decide who needs to know what. And sometimes you can make the mistake of saying everybody needs to know X, whereas actually you can find yourself in a bit of a predicament there where you start going down that rabbit hole of potentially mandatory training. You mentioned that there will be EU legislation towards that. And indeed, you mentioned about medical schools. So interestingly, the Medical Schools Council, I don't think it's been formally published, but I've had eyes on it. Last time I checked, about 3 or 4 weeks ago, hadn't been published. They are actually creating an AI curriculum for medical schools. And I know Cardiff University, who I've worked with, are now from next year. You said it's been optional. From next year, there will be some mandatory workshops and training with respect to AI. So I think there is definitely movement in the right direction. But I would echo absolutely what Nick said with respect to trying to decide on that curriculum and what it should involve, especially as we're something of a self-selecting group, right? We are biased towards how excited we are about AI, how important we think the risks, challenges are, and that people need to be educated towards that. So we're probably not really representative of the workforce as a whole, and I think that's why it's so important that, you know, the Turing are doing so many workshops, and we're trying to kind of feed into the AI Commission that the Welsh Government is leading to try and make sure that we really have mapped the ecosystem so that we are doing what people want and need and not allowing our own biases to say, oh, right, well, this is what everybody needs to know and this is what we're going to do. And one of the earlier panels mentioned about the importance of patient engagement. And I think that is clearly very, very important because that should feed into, you know, how we shape these education pathways. And I think that's a big... the doctors, the medical staff, and it's not just doctors, is it? It's all clinical staff and potentially even clerical staff. They need education in this because they will be educating the patients a lot of the time. So, yeah.
There's a lot of people to consider here, and actually you mentioned about the patient engagement and representation too, and I'm reminded of the talk that we had a little earlier on and the statistics or the numbers that came out from what Nell was saying, which was, you know, trust in artificial intelligence is particularly low in some of the lowest socioeconomic groups, but also, paradoxically, I thought, in actually younger age groups as well, just there. And I don't think it would be unfair to say that we might see that mapped across to more widely. I mean, in your experience in the work that you do, I'm talking clinically here, what do you think the current level of understanding is? Just your observation. I'm not sort of holding, this is not a statistically significant thing or anything like that, but what's your observation in your own practice?
Of interacting with patients and their
well,
degree
maybe the
of
two,
literacy.
you know, your colleagues, the clinical and non-clinical colleagues,
Yeah.
the sort of professional side, but then the patient side, maybe both of your observations.
Yeah, okay, that's really interesting. So it's difficult to get a true straw poll. It tends to be when you give a talk about some element of clinical artificial intelligence, and then you ask for a show of hands as to how many people are using it. And you know, I give some talks around clinical AI, but I also give some talks around rheumatology. And it's really interesting to see how different those two groups are. And just alluding to the really important point that Alex made, which is around this concept of an echo chamber. We are currently sitting in a digital health, AI-savvy echo chamber. And what we need to really make sure is that as these different developments move ahead, be it, you know, a medical school curriculum, a national curriculum for AI, that stakeholders from across the distribution of AI literacy are included in that. But just in answer to the question of how many, the literacy of colleagues, I'd say it's actually really still quite low beyond, you know, a knowledge of the ability of ChatGPT to be able to create Christmas cracker jokes.
Yeah, I would echo that. I think we did a survey of nursing and midwifery staff in Wales, just using a scoring system, you know, 1 to 10, and we found that there was a negative net promoter score for every question with respect to AI. Do you think it will help? Do you think it will reduce time? You know, are you positive towards it? It was all negative, but the only positive was we want to learn more. And I thought, how interesting that that's borne out in the evidence. The more that people learn, you know, in healthcare staff, the more they learn, the less the culture of fear that it's going to take our jobs is a problem, because you start realizing there are issues. And also, you mentioned about ChatGPT, and you mentioned about Ethan Mollick saying you need to use it for 10 hours to kind of really even gain a basic understanding of what it's good at and what its potential use cases are. you have to use it enough to start making mistakes that are very low risk, I think, because the first time I used ChatGPT, I thought it was magic. And I'm sure other people will feel this, oh my gosh, I never need to think again. This is going to make my life so much easier. Just let it do all my work. And then you make a mistake and you send an email that's got this ChatGPT tag at the top. And it's very embarrassing, but my feeling is until you've done that, you probably haven't played with it enough to start realizing that it hallucinates, that it makes stuff up. And then when you ask it, I know the newer models, how many R's are in strawberry, and it says there are 2. Well, once you understand why it thinks there are 2 R's in strawberry, it totally changes your mindset into the potential use cases and when it would be really, really helpful and when it could be very, very problematic. So I think that the general literacy at the moment is extremely low, is what we've found. 1 in 5 GPs, though, are using it. You alluded to that statistic earlier, and I think that's a really frightening statistic because 1 in 5 GPs have not had training in how to use AI. So I think the literacy is low, but I think there is definitely an appetite to learn more. But unfortunately, we're not giving it to people. You know, those formal education pathways aren't there, and that's kind of what we're trying to work on in Wales.
Yeah, I mean, it is kind of worrying. I sort of think about, the first thing that you do when you learn how to drive a car isn't immediately just take it straight out on the motorway and just have at it. There's a sort of graded entryway into it as well. And I mean, it's part of the reason that I give talks like I gave earlier on about the use of artificial intelligence and the sort of the principle is like safe, playful experimentation and trying to get people to use it elsewhere, on the things that are lower risk, because it will make mistakes. But you have to be able to make these mistakes to understand of where it can and can't be used. You become more a critical user of these technologies and away you go. So, yeah, I mean, and of all of those things, that everything is negative apart from the fact they want to know more. Well, I'll take that, because that's the way in, isn't it?
And the other thing that is said is the companies that create these models are rubbish at saying what the use cases are. The way to find the use cases is for people like us to start utilizing it in our day-to-day lives and thinking, there's an idea, and there's a way that it can be really well used and resourced to kind of, we keep using the term today about square peg, round holes, and often it can be a way of squaring that circle of how do you offer tailored education to such a vast workforce as the NHS. A porter doesn't need to know what a consultant neurosurgeon needs to know about how AI can help them, but they probably still may need to know something. So yeah, I think that there's definitely a positive in using it. I think you just have to be careful about finding the right use case.
Nicholas?
Yeah, I was just going to say that from the point of view of the use cases, obviously those will rapidly change with development and enhancement in the field. And so one of the key things when looking to define a curriculum in any space is to ensure that it's going to be flexible. And we see this in the national curriculum for computer science. It's left quite deliberately fairly vague so that what's put into writing, what's kind of etched onto stone, actually is flexible enough to be able to move with the times and to include the developments that we'll see within AI in clinical practice.
Yeah, and it is moving at one hell of a pace as well. And actually one of the notes I'd said is that how we keep this up to date. But okay, so we've talked a little bit about the who of this, and then you actually set it up quite nicely. There's the who, there's the what, and then there's the how. So maybe we can spend a moment or two thinking about what we think might be the core components of a curriculum, and any you think are just like nailed on, and other ones that are maybe so optional. So any thoughts there?
Yes, plenty of thoughts, none completely defined, but obviously there's got to be something around the kind of background, the theory behind machine learning, and essentially being familiar with some of the terminology. Certainly from a medical student point of view, and some of the kind of Delphi studies that I've seen published, which incidentally always seem to include a panel of 18 experts in artificial intelligence and healthcare, hence the echo chamber point earlier. But they kind of start with an introduction which is around these foundations, how you go about defining the accuracy of an algorithm, for example. Ethics, of course, has to feature prominently, as does legal aspects and regulatory, and then also some more practical elements. So how are they used in clinical practice, and how they're used in interactions with patients, and then how do you explain to patients how these tools are being used, how they're influencing their care so they can be truly consented for their use in their clinical care.
Yeah, and that sounds like a really sensible decisions for about those that will be using artificial intelligence. And I mentioned earlier on today the reports that were brought out a couple of years ago from HEE about assessing confidence in AI, building confidence in AI, and the definition of these 5 different archetypes from users, implementers, builders, drivers, and shapers at the top of this. So we've got this sort of core chunk within there as well. As you sort of move, away from just the frontline users, what additional things do you think are important for those people that are implementing the technology as well? Because it's not just about just using the tool that's in front of you; it's getting them out there.
Yeah, I think that's obviously very important, and I think that we agree with you very much. I think it's clear that there is a foundational element that everybody does need to know, as much as I hate saying that. And I wouldn't disagree with any of the kind of spine of what you said there. I think the problem comes then is how do you make that specific to somebody's job role, and also specific to those archetypes that you mentioned. I've done a lot of work on this, and I haven't found a better framework for that. And if you look at industry, a lot of them are using persona. It's basically the same thing, archetypes, personas, and it's really, are you a user, are you an implementer, are you a creator, embedder, and so on, just maybe with different names. And that really does, in those 5 terms, you can encompass the whole NHS workforce. And I think what's really interesting is that if you can then start building models and that will essentially, very good chatbots, you could then, something that came up at Turing that was very interesting was with respect to procurement. Mm-hmm. So I think there's a real lack of education around procurement. I don't know anything about procurement at all, but as a GP, an ambient scribe can come to me and say, we've got this software, it'll help you, do you want it? I don't know the right questions to ask. There's a skill in procurement, and the guys in the hospital that are procuring our hip replacements and our tongue depressors and so on, they're probably not adequately trained in procuring AI technology either. So I think what we can do, you mentioned earlier about your custom GPTs, is you could create a custom GPT that will talk people through the procurement act that's about to come in, so that GP can say, I'm thinking about this ambient scribe, talk me through the procurement of it, and it'll give you this step-by-step way of doing it. So I think each of those archetypes, they need to know there's going to be very different applicability. And when you look at the digital capabilities framework, which is a little bit out of date now, that was done by Health Education England, 2019, I think, there were great different levels there, and they did tie them into those archetypes. It was a brilliant framework, something that we definitely are looking to pick up and take forward.
Yeah, there's some really good sort of materials out there, and one of the things, when we had our preparation call, we kept coming back to, like, we don't want to reinvent the wheel, we don't want to sort of duplicate efforts, which is why it's great to have, Turing and the England representation, and sort of speaking to more national. Then we got Wales in here too. Would equally want to have a similar look at what's happening in Northern Ireland and Scotland as well, to start to bring that in together. I think we'll come back to using ChatGPT and so on to do the teaching side. And obviously I'm worried about this, what about hallucinations and bias and everything like that. Okay, well, we accept that might be in there, but there's something very nice about the technology that we're teaching people to use, being involved in the teaching and personalization of this technology as well. And of course, we've also got preference for things like YouTube as platforms, TikTok, similarly about this sort of snack size information being out there. So there's a lot of different ways in that we can maybe come back to. So we're sort of progressing up this line. We've got the implementation. Just going to dwell a little bit on the sort of the next archetypes, because I agree that they're really good. I sort of see myself in, sort of the builder and other parts of this as well. And maybe there's some people here as well. I certainly speak to a lot of doctors who want to get into health tech and start involve. Any thoughts on what they might need within there?
What they might need in terms of how we're tying that into those framework.
Yeah, if there was a curriculum, and I'm just trying to think for those people that want to get involved in. Maybe we'll broaden it out a little bit, and I can come back. I can speak a bit to the procurement side of things, but people that wanted to get involved in the actual building, either within the NHS or outside the NHS. Any thoughts on what they might need?
Well, I think they need a grounding and an understanding, essentially, to begin with. And at the moment, you've got to carve your own path for that. And as you said, I think medical students now, there's no excuse for, certainly year 1, year 2 students now should be coming out very literate, I think, around AI and its use cases. As Nick said, things are going to change very quickly. So I think it's very difficult to tell people what they're going to need to know in 3 years. Because, for example, prompt engineering at the moment is a valuable skill to be able to. In 3 years, that's probably not going to be valuable. You're probably not going to need it. You're probably not going to need to prompt engineer because the models will have accelerated to such a point. So I think it's really difficult to tell people what they're going to need if they want to do something in 6 months, a year, when they qualify in 2 years. But I think that the one thing we probably all agree on is we need to give people the foundational tools to equip them such that they can ask the right questions, they can understand that basic literacy. I think there's a really important piece around the definitions that we're all using, because I think when you can lose people very quickly when you've all got slightly different definition for what AI is. And I would point people to the NHS AI Lab dictionary, which is what I tend to have as a go-to when I'm speaking to make sure that I've got this kind of standardized language. So I think you've really just got to throw yourself into it. I mean, the role I took was a banding below what I would have normally been looking for, but I was happy to do it because it was such a great opportunity to get my foot into this world. So I think it is a growing area. So I think if you're really committed to it, and you kind of try hard enough, there's obviously the Clinical AI Fellowship, which I would wholeheartedly support people looking at. There are opportunities there, right? I just think that unfortunately maybe not quite enough yet, but hopefully that's going to grow.
Yeah, to say that absolutely, Clinical AI Fellowship, amazing. Harris and Alex Deng, brilliant work. Also, there are some very good online courses and resources through places like Coursera, and that's somewhere that I quite often point people towards. Just on the kind of the whole point about who needs to know about AI within the NHS, and I think that I've definitely moved from somewhere where I was probably sitting with an echo chamber where I was thinking that everyone needs to know about it. What I think now is that everyone needs to be aware of it, and also but just have access to education if they need it in certain cases. And then there would be certain areas, for example, in clinical practice, if you're actively deploying those tools when you do need to know about it.
I'll tell you something that I find really interesting is if you, a lot of these models that are now being used, and a lot of them are not medical devices, so they're subject to collecting more data. But the people using those models, for example, if it's endoscopy and computer-aided endoscopy detection, if it's radiological models, most of their training and knowledge has come from the people that are bringing them the solution. Whereas if you had if a drug rep, I use this analogy a lot, and maybe it's a bit disingenuous, but I think it demonstrates the point. If a drug rep came into my room and said, I've got this new drug, it's really good, and it really helps with this problem, I say, oh great, I'm all ears, what's the evidence? Oh, well, we haven't done any RCTs, we haven't done any prospective RCTs, right? Well, how have NICE and MHRA signed off on that? Oh, they haven't, but we promise it's really good, and it's safe, and it's really useful, and you don't need to ask for consent from the patient. You'd laugh them out of the room, right? But with AI, unfortunately, at the moment, it is a bit of a Wild West in that sense, in that somebody can just come and sell you their model, and it's not, I know Hugh has some views on this in terms of what should and shouldn't be classed as a medical device, and some things that aren't at the moment, maybe in the future will be. And again, people are able to procure these solutions now with no real understanding or basic knowledge in what are the right questions. What was the training data? Would be a standard question that we would know to ask. These people don't know to ask that question. We talked about skin color and so on earlier with some of the dermatological stuff. That would be one of the first things I'd think to ask. Whereas I think if you're not equipped with that knowledge, you wouldn't necessarily ask it.
Yeah, I suppose it's interesting sort of pulling on this a little bit more as well, because when I think about I'm no longer practicing as a general practitioner, but whilst practicing as a general practitioner, I had a lot of my grounding about, pharmacology, biochemistry, chemistry, and everything like that, and I would make my decisions and so on, and I would understand some of the basic processes, like sort of the foundations of this, but I wouldn't make it something that was top of mind all the time. I would just assume that someone else had done that work, and I think when it came to the prescribing and the drugs I was prescribing, for the most part that was true, it was done. But we're in this sort of weird middle ground right now, aren't we, where, well, you'll say, well, if they do it for drugs, they should do it for this, but of course it's not being done. But I think that it would maybe not be necessary to know the fine detail of what would need to be done for a person practicing to know that. They'd need to know that it had to be done somewhere and what the role of it is. But those questions about the evidence base, I think, fall more into the kind of procurement level.
Yeah. Very fair point. I mean, there's talk about the AI catalogue, isn't there, where there's going to be a list of kind of authorized solutions, which I think would be really, really valuable. And I think that the position we're with this Wild West at the moment, almost where you can just kind of take it on and hope for the best. And I've had conversations with some of these companies, do I need consent or no? And I think, well, hang on, there is a risk it could get things wrong. It could hallucinate, and that has a material impact on the patient. If we lose ground truth in the notes, there's a real cascade here where things could go quite wrong quite quick. How can we say that we don't need to ask for consent for that? And I'm not saying I think we definitely need to. I just think that that's a real conversation that needs to be had. And to come on to your other point, a lot of those models are being used in organizations with big procurement teams. And I think that gives you some peace of mind, doesn't it? That if you know it's being used in Great Ormond Street, then you think, okay, well, I haven't done the procurement work for that, but somebody clearly has. Maybe there's a collusion of anonymity there, and it's maybe a bit of a risky approach, but I think it's probably human nature that you would look at things like that.
Just to say also that, so rather than taking things directly straight into clinical practice, one of the things that's really satisfying about being a researcher is being able to take them through clinical trials, and that's one of the things that we're doing at the moment with a couple of companies in the osteoporosis space within Southampton as well. It helps you to get under the hood and also to then work with the companies, but also gives some kind of structure and a safety framework in which to start to kind of softly deploy these tools.
We'll wrap up we've had the who and then a little bit of the what. We're going to come on to the how in a second. Before we finished up the what, that sort of last tier, the sort of drivers and the shapers, is an area that's kind of close to my heart because of the work that I've done in medical leadership and studying medical leadership. And there's still, sadly, a sort of sense that there's a kind of management leadership kind of dark side that people disappear to, and they just say no to stuff and force you to do things. But as long as we can park that for a second, I have also found in having conversations at that level that the level of understanding about artificial intelligence, even the foundations, can be quite low. And to that end, I at least give people some reassurance that actually there's a lot of work happening in this area in leadership training for AI being brought in and different ways in. And that sort of mission to build a better buyer has been something I've had an opportunity to do at Bayes Business School with the leadership teams there and teach them and actually get people coming in from industry side and saying, look, the act of getting this thing that we are selling is not just entirely mercenary. Like, we want to get this great solution with you, and we want you to be a really engaged buyer on this side as well to understand this, so you can ask the right questions and be involved in this.
Yeah, that chimes with one of the points that came out of the workshop that we ran, which is around AI champions. I mean, I guess that we are actually now blessed in the current generation in the NHS with clinical information officers who are representing, clinicians on health boards. But the idea of a kind of AI champion who's a bit like a Caldecott guardian for ethical issues, and having someone in place like that in a position of leadership within a hospital would hopefully serve some of those purposes that you just talked about.
Yeah, that's actually a really lovely, I hadn't thought of it that way, but yeah, the Caldecott Guardian approach is quite nice, that you have that kind of responsible, accountable person that understands this deeply and then makes sure that those responsibilities are discharged with appropriate level, train people below that. So, well, then we're inching towards the how then. Okay, so we've got some of the components of, we know roughly who, the what. So how? How do we do this? And I know, Alex, that you've got an interesting video to show. Do you want to sort of, before we show the video, and then we'll come back on to you, Nick, talk through what you've been doing, and then we'll maybe run the video demonstration.
Thank you. Yeah, so we had the idea of our strapline of using AI to learn AI. So I mentioned earlier, and Keith alluded to, you've got to use it, you've got to spot the problems, you've got to have this dialogue with the AI to really understand how it works. I was going to say how it thinks, it doesn't think how it works. So we've we're going down the approach of building a foundational piece, which is basically 4 or 5 interactive posters of what is AI, what are the main risks, what's the potential for the bias. The list of bias is this long, it's a degree subject, but we're really zoning in on automation bias and algorithm aversion, so either being too ready to accept the outcome or avoiding the outcome. And there was an interesting article in JAMA about doctors actually doing worse when they had ChatGPT than the ChatGPT by itself. It's not quite as simple as that it sounds when you dig into it. So then the next step after that was, because I started thinking, I'm obviously biased towards doctor because I'm a doctor, and so no, it's not just doctors. You've got to think about nurses. Well, it's not just nurses, physiotherapists and opticians and pharmacists. And then no, it's not just clinical people. You've got to think about the education for the non-clinical, the clerical, the administrative staff, the executive staff. So I was sat there thinking, well, that's impossible. It'd take a lifetime to create educational material for all these people. So we kind of had the brainwave to maybe use a GPT and use a large language model that we could fine-tune and train, and then people would be able to have this dialogue. So tell me about how AI can help me in my role, whatever that might be, trying to get them to link that into the archetype that they would most associate with, because I think it's a really interesting way of looking at things using that archetype framework and becoming familiar with it. And then very much focusing on more the risks and the potential for biases within those applications. And of course, this can go back as a dialogue, give me some specific use cases that are in the NHS. Now, we've created a proof of concept. It's not a finished product, but we are at the stage of taking that from proof of concept to an MVP, hopefully in 25, 26, that we'll be able to roll out to our staff.
And this is the bit that I always get really excited about, because I'm like, oh, this is a really interesting challenge. Like, how would I do this? How would you wrap Sora into it to create the video content and auto? But I'm not going to subject you to all that just now. We're instead going to roll the video. So can we maybe have the video demo here? We don't anger the tech gods.
So I'll try and be quick because it's quite fast. So this person has said they're a nurse, and then it's asking you, well, which of the archetypes would you identify with a brief summary? And also asking you whether you would class yourself as a novice, intermediate, or advanced user. So this person has said they're a mental health nurse, a user, and a novice. And then the AI, sorry, this might be a bit slow, then the AI will tell you about the potential basic applications in your field, and then going into talk then and focus on the potential challenges as well, the risks and the potential for bias, things that you need to consider. Clearly, when we talk about risks, we're talking a lot about the ethical side of things. And in the previous panel, there was a lot of mention about the equitability side. And I think that's something we would definitely want to build into any model. And so, I mean, you kind of get the idea then. So you could ask about specifically, how could AI help with identifying, this person is a mental health nurse, identifying a patient at risk of a mental health crisis. So then that gives you more specific applications with things like natural language processing, where it could pick up on potential red flags. You know, if it was trained on, it should be fairly easy to do the more we use natural language processing to spot potential markers for high-risk patients, as well as some others. And the video rolls on. I've kind of done another one then for, I think, a hospital porter, and then I've done another one for a consultant neurosurgeon, just to demonstrate, whilst we've given them this foundational understanding, which is very brief. This is not like clicking through an hour's worth of a slide deck. It's 4 or 5 interactive kind of captions and animations, posters of what is AI, what are the main couple of risks that we need to be cognizant of. And then the next step at the end of that is if you want to learn more, because as Nick said, not everybody does. Everyone needs to be probably aware of it. But I don't think we can start saying, right, now everybody needs to become an AI expert. But if you are inclined, then you've got the option of further exploring your the applications for you using this tool, which we're hoping to continue to develop and improve, because as I said, this is a very basic proof of concept at this point. So this has been mainly created just through quite in-depth prompt engineering. The plan is to have quite a lot of retrieval augmented generation, or RAG, so that we can make sure that we've got some very reliable sources of data in there to try and minimize. You can never completely eliminate, but minimize the risk of any hallucinations or any potentially inaccurate information. My argument to that, though, is that I think this is quite low-hanging fruit. I think the potential for risk in an application like this is actually quite low. There will be guardrails put in place to try and minimize the chance of anybody jailbreaking the model. So hopefully the benefits outweigh the risks. And somebody else earlier mentioned in a question about letting perfection be the enemy of the good. And I think whilst we have to be cognizant of the potential downsides, I think we have to change our mindset somewhat in the NHS, because we are in a system that's really creaking at the seams, to put it mildly. And I think we have to move from this risk avoidance that we've all kind of had drummed into us. You can't do anything that could have risk. And we need to go more to risk management, because if you're waiting hours for an ambulance, and if you're waiting for months on a waiting list, as somebody alluded to earlier, that's a place of harm. There's a chance of harm there. So maybe accepting a small amount of risk in that may be a net benefit.
Yeah, well, managing risk, spoken like a true GP, and living in that life in the grey and everything, and of course doing things quickly and enough. Preaching to this choir here. Oh, that's great. So this is a wonderful sort of way in of taking that incredibly dense sort of possibility space of all these combinations that you need to get something effective out in front of someone. At the Turing, what are you looking at here? Maybe, I don't know if you're looking at chatbots, but what are the sort of ways you're trying to take the work that you've done, or thinking of taking that work forward?
Yeah, well, I mean, we're using the convening power of the Turing to take everyone else's ideas and to help them move them forward. And I mean, this is just a brilliant tool. It's a brilliant concept. It's such an innovative way of going about teaching something like this. We're all so familiar with death by stat and manned training, aren't we? And if AI was just to appear as another one of those presentations that you have to kind of click through each year and then answer the quiz about at the end, that would be really sad for everyone.
I think we'd all lost out, and we'd probably get a model or an AI to take it through, run it for us, and then we just got AI.
That actually came up, didn't it, at the Turing, that we should, incognito, it should be embedded within data governance mandatory training.
Yeah.
I was like, no, you can't. I don't want it to be kind of in that group. Yeah. We want people to be excited and to kind of want to interact with this, right?
There is that the element of stuff. Just thinking about, because I think we've moved on to the how now. So how you actually kind of spread this. I guess that in a medical school curriculum, yes, it's brilliant that there is a new AI curriculum, but there's no space on the curriculum. And yes, like medical schools are all redesigning them because of the new licensing examination that's coming in. So maybe this is actually the one kind of ripe moment to try and introduce something else. But otherwise, I think we're going to have to use stealth and introducing AI in stealthy ways, like, in the ethics module, including elements of bias or health equity, in a section that's about evidence-based practice, talking about how you go about interrogating some of the tools that are being used or how they're developed. And obviously that is trickier when it comes, so that's for a medical school curriculum or something like that. It's much harder when you're looking at the wider workforce, because otherwise you're going to be, doing your manual training, and it might say something like, lifting a box. Have you heard about black boxes? And then as a kind of seamless segue into training about artificial intelligence.
The robot that is lifting the patient has how do you assess that the model is up to date for taking this person from X to Y? Yeah, sorry, you were going to say something there, Alex.
Yeah, just interestingly, when you talk about the medical schools, what I found interesting in my conversations with them is there's very much an appetite about educating students about AI in education and academic integrity. They're finding time to make that a priority. And I'm not saying that's wrong, but I think it's a mistake in that I think we should be looking at AI and thinking, how can we, kind of like Ethan Mollick does with his students, everyone use AI, learn how to use it well, the quality of the output of those students increases, the number of questions that get asked in lectures reduces because people ask the LLMs, the quality of the questions that do get asked goes up. And you think, well, this can only be a good thing for the end product, which is a graduate in whatever specialty, but if we're talking about medicine, that I think could surpass the kind of current standards that we meet when somebody's gone through 5 or 6 years of medical school. So I think we really need to try and flip it on its head and be cognizant of the risks and the downsides. I think we all are, but how really get excited and explore how can we actually produce different caliber of medical students, medical graduates, by utilizing this. How much more can they learn about when they're not sat in lectures, scratching their heads, going home and having to spend hours trying to work out the Krebs cycle, when actually you could explain the Krebs cycle to me like I'm a 12-year-old. Oh, right, and I get it. And for most, that's probably enough to get you through your medical school exams, and then you can move on to the next thing, and you can start applying this physiology. Whereas actually in the real world, you have your physiology, your biochemistry, you qualify, you come out, and after about 8-9 years, you start thinking, oh, that actually ties into what I learned in those physiology. When you're in the real world, you become more experienced. So I think it could have a real, if we can get it into the curriculum, but also to really open people up to use it and not say, oh, this is a red assignment. You cannot use AI in this assignment. I kind of think, I don't know whether that's the right way to go. I don't.
No, I was just going to say that I was giving a lecture to the first years at Southampton, and I was there early and sitting at the back for the lecture beforehand. And it was amazing to see how many had ChatGPT open in front of them. Lots of them also had TikTok as well. But there were some really good questions afterwards. So maybe there's a direct correlation between ChatGPT usage and quality of questions after lectures.
No, fantastic. Well, look, I really want to make sure that we leave a little bit of time for questions as well, so I'm just going to take a pause there and say we've covered quite a lot of ground, but there's some really interesting ideas about how to take this forward. So going from how Hugh did this earlier on, could we get a little mini round of applause for our panelists here just now? We're going to try and we'll get as many applause as possible. Okay, but at this point, it's over to any questions. So we've maybe got about 5-10 minutes. So does anyone have any questions on this topic that they'd like to ask? Oh, everyone's like, oh, there's one at the front. Okay, we're going to go to the front, and then we've got Erica, and then to the back. So Erica, you're up first. No preferences being done here? Oh, no, we'll go to the front then.
I got a question, and so for Alex, you showed the one in English. So have you developed the same large language model in Welsh? Because so when Netherlands they deployed the large language models, so they found out some of the acronym in Dutch is not working very well for large language models. So I just wonder if you have tried that in Welsh and then deployed AI, and then especially in medical field.
Thank you for pointing that out. I think that's something I should have mentioned. So at HIW, one of our principles absolutely is that everything we produce has to be produced in both English and Welsh. And that's kind of coming from the top down with the Welsh government as well. That uses OpenAI, the one that we've used there, and we are kind of pushing the agenda to continue with OpenAI because it does have one of the best abilities in translating into Welsh of the large language models. And I've done I'm not a fluent Welsh speaker, so we need work on that to actually really evaluate, but we're very hopeful that will do a good job of that. And it's certainly something that I think if it didn't, I think we probably wouldn't be able to do it. So it's actually a prerequisite for us is that it will be able to work as well in Welsh as it does in English.
It'd be great to see the Welsh version.
Are you fluent in Welsh?
Araf?
Araf, yeah. You've driven in Wales, obviously. Yeah.
I go to watch rugby at Millennium Stadium quite a lot, which is, I have to say, the best rugby stadium that I've ever been to.
I concur.
Murrayfield, come on. No, it's
Haven't been to Murrayfield.
There we go. Of this. Okay, right. So, well, this is fantastic. So, thank you. Yeah, I mean,
Great
it's very,
question,
very
thanks.
important to make sure that the first language, spoken language, but also comprehension should be done. This is an excellent point. Next up, I think, Erica, you got the mic.
Yeah, thanks. It's been a great panel. Thank you very much. I'm Erica. I work with Keith at Curistica. And I'm curious if you think that in education and training, there's a place to address some of the psychological challenges with integrating AI into practice, especially for people that have been practicing for quite a long time. And, you know, we're trained to be a doctor or a nurse in a particular way, have been doing that for a very long time. It's associated very much with their identity, right? Their feelings of worth and meaning, and you know, quite suddenly these tools come onto, you know, the field, you know, and start taking over some of those roles. And just curious if you think that addressing and at least voicing some of those challenges is part of this kind of curriculum, and if that you think that's important, and is that being discussed?
Good, very good question. So, any thoughts on that?
You might know who said it. I always forget who said it first, but AI won't replace us, but it will replace the people that don't engage with it. And I think that's kind of the strap line that I would push. And as I mentioned, the evidence really tells us that the more you learn, the more enthusiastic you become towards the potential applications. So I think the key to the answer to that is to educate more widely, because people's initial reaction, you know, I've got friends who are very close to, like, you know, cardiology trainees, and they're going into imaging, and they're genuinely reconsidering that, whether they want to be cardiologists specializing in imaging or not, because they think, hang on, AI is going to replace that job, I need to be more of a doer. So I think it's a really relevant point, and it's something that people are grappling with for sure. But I think as they learn more, I think actually probably their fears are somewhat allayed. But the other really interesting thing is that AI, initially, we thought it was going to replace blue-collar jobs, you know, our heavy goods vehicle drivers, et cetera, whereas actually now things have changed, and we actually think it is more likely to replace white-collar jobs than it is blue-collar jobs. So I think time's going to tell on that, but my conviction is that the answer is educate. You know, make sure that people have a level of education where they are at least, it's the fear of the unknown can be the problem. So if we can try and alleviate that, I think we've gone some way to mitigating the problem.
Yeah, I was going to say, I mean, that will help, of course, but it will replace jobs. I mean, this is, you know, there's also some absolute fact in this as well, and I think it's really well-raised point, because I think some of the kind of duty of care we have to help people with this transition, because as they learn more, sure, they'll feel a bit more confident about some things, but then they'll obviously see some facts in front of them as well. So I think that's a really good point to pick up in there about how do we deal with changing roles, and yeah, that level of threat will stop people absorbing or engaging, won't it?
I think that, I mean, you know, certainly in the NHS, we're kind of strapped at the moment in terms of number of staff. So I think that it's certainly, I don't think in anyone's immediate horizon that their job's going to be replaced by artificial intelligence, at least in the clinicians that I speak to.
Great, thank you. Any more questions? We've got, I see there's a gentleman just back there, and then we've got one more question at the end, and we'll check the time.
Hello, my name is Hamza, and I'm a final year medical student at Manchester. And just before I ask my question, one thing that resonated with me was ChatGPT with students. No hyperbole, I've made all my notes with ChatGPT since third year. So while people were making notes, I already had all the notes in my head. So it makes a big difference. But on to my question. I've always been into kind of health tech and innovation, and I'm on the verge of starting a new startup. And one thing that I've learned from this conference is collaborating with clinicians right at the start is so important. So what sort of ideas did you have in terms of educating clinicians on co-designing, co-collaborating on new technologies with startups? Is that something you've thought about?
I mean, I can answer some of this, but yeah. I know I spent a lot of time thinking about this, and it's still not absolutely solved, so I don't have a definitive answer on that. And actually, Derek's talk just prior to this probably covered quite a bit of that and what he's doing. So with Adopt-a-Doc and trying to make clinicians who have an interest, making it very, very easy for them to start engaging with the wider industry more widely as well. In part of what I try and do is try and emphasize the benefit and importance of this as well for all sorts of different reasons. So industry will start to pull people towards them as well. So, but that's on the industry side. I still think it would be a great shame if the NHS didn't also start capitalizing on this and start saying, well, there are some roles for you in the NHS. At the moment, there doesn't appear to be anything there. Now, entirely how we address that, I'm not so clear on. But certainly, the advice I give to people who ask this question is generally about it. While we don't have a sort of firm way of doing this, it's all about trying to expand your network. It's doing things like connecting on LinkedIn, coming to events like this, attending events where there'll be other sort of health tech companies, and speaking with people and availing yourself of the opportunity to have conversations and learn from them about what they do. And as they learn more about you, they start to pull that information in. And when it comes to getting roles in health tech, if that's what you're looking for, there's an element of kind of getting to know you and building that trust, and then before you know it, you're sort of brought on to do little bits and pieces to help out with. And I haven't seen any more formalized ways of doing that right now, but I've definitely seen an uptick in interest in hiring. For example, like after a long time, I'm starting to see some bigger companies putting out specific roles for clinicians to come into, so entry-level posts and so on as well. So maybe the tide's turning a wee bit there. But I still think that that's all great. But my goodness, the NHS is losing out. It really is. Because everyone who has the capacity and the vision to do this will leave, and not all will come back.
And you will definitely already be aware of this, but things like the Clinical Entrepreneurs Program, which is really successful, amazing work going on through it. And I guess that would be one way to engage. And also the Clinical AI Fellowships as well, which are hosted through King's College.
There's a few others out there as well. There's Bite Labs and a few commercial offerings as well to try and get in there. But LinkedIn, find the groups, connect, network, your own groups within Manchester or wherever else as well, and grow from there. As we get more people engaging, more formal paths will emerge, I think. There was a question at the back, and then maybe we'll wrap up with a question at the front. Just right at the very back there. Keep going back. There you go.
Hi, I'm Naomi. I'm a final year medical student as well from the University of Leeds. So quite a similar question, just as someone who's about to graduate and thinking about developing, me and my friend are thinking of developing our own app as well. How can we get more hands-on experience with AI when a lot of the opportunities seem to be tailored for people in, sort of further down in their career?
That is a bit of a challenge. I don't know.
Yeah, so the Clinical AI Fellowships do hit this kind of sweet spot. I can't remember what level you have to be at. Do you have to be in specialist
trainee? Yeah. So you're too early on for that, I think. I'm not sure about the Clinical Entrepreneur Program, but I think that's open to everyone, actually.
But the fellowships, I know that is something that Alex and probably Harris as well are looking at, because it's not available to consultants either. And so, hopefully those things will open up. But don't let that put you off doing your exciting new application.
Absolutely. And then just one final question here at the front, and then we'll wrap up.
Hi, my name is Saeed. I'm an AI engineer by background. I started an online community for doctors to learn about AI. My question is, what is the threshold that doctors need to learn? Because what I found out after we explained the basics, like machine learning, neural network, there are certain they aren't really used with big software that they are interacting with on a daily basis. So there is always evolving technology, but I don't want to teach them like everything. So what should you do?
So just to clarify, so you've got an AI education program for clinicians.
No, it's like more of a community called the Medical AI community,
Okay.
where it's news, free courses, and podcasts, stuff like this.
And what threshold should people meet before they're able to use AI in clinical practice? Is that what you're saying?
What I said is, what threshold should the doctor interested in AI learn?
If I understand correctly, you're maybe check you're asking a question is you can get the basics, but you're asking what should they learn next that would actually be practically applicable, because maybe what you're thinking is things that they won't have a chance to use. They'll be too abstract or theoretical. Is that your question? Yeah. So going from that sort of foundation, what do you think would be a core component that would be useful to them next, maybe?
I think it completely depends on the individual and the way that they're using AI in their clinical practice. I mean, I suppose that the clinician confidence in AI and developing clinician confidence in artificial intelligence provides that framework whereby you can pitch it to different levels according to, the need of the clinician.
For us, we mainly explain like software like ChatGPT and stuff like that promote productivity within the doctors themselves, not necessarily within medical AI software. So do we need to explain things like why ChatGPT can't know how many R's in strawberry, or
Yes.
why videos can't model hands really well?
Yeah, I think that's
Or not.
really. I think that's really important, and I think kind of I alluded to that until you understand that, I think you're at risk, particularly if you're using it in a clinical setting, which we know we shouldn't be, but people are. And I think if you're using it in a clinical setting, but you don't know why it thinks there are 2 R's in strawberry, that's a problem. So I think that it does depend on the person, and I think again, I come back to the archetype framework. I would say it's probably more relevant to that rather than your specific role. If you're using an AI model and you're a gastroenterologist doing endoscopy, you do need to know about the device and how it works in that specific setting. But you don't necessarily need to know about convolutional networks and so on. You need to know it appropriate to the use case. So I would, whereas if you're creating the software, coming back to the archetypes, you do need to know in depth about the technical aspects. So I think it really depends on the role, but also on that archetype as to where you need to go. But I think you have made a really important point, and kind of, I guess, what I was trying to say less eloquently with the medical students is teach them. Don't spend £50,000 a year on a simulation tool for communication skills. Teach the medical students how to create a custom GPT for communication skills. To me, that's a far better use and of money and resource and time, and it's a lot cheaper. And then the medical student can use that knowledge to also create a custom GPT that teaches them about medical statistics to pass that exam. That to me is far more useful education than this is how you use the AI for this one. These are the risks of it. Actually teach them how to utilize it in their day-to-day life so that they can spot the use cases, as we've already mentioned.
So hopefully some food for thought on that one there. So, well, look, great, we've wrapped up. So we had the mini round of applause, but now we need the maxi round of applause for our panel here. Thank you very, very much. We'll be around just a little bit at the end. I'm just going to stand up for one moment. It's okay, you can start leaving, don't worry about it. I'm just going to say thank you all for staying to the end today. Just some other things. See this QR code up here? Please complete this survey. This is about your understanding of AI pre and post here today. So thank you for that. Thank you for coming along. And any and all feedback would be fantastic. So yes, get back to us. We'll hopefully see you here again next year, and there'll be plenty more opportunities to learn more about AI going forward. Thanks, everyone.